for registered nurses and CNAs at Lincoln, helping patients start and stay with insulin during clinic visits. People with type 1 diabetes have complete destruction of their beta cell function and require daily insulin. And the progressive nature of type 2 diabetes causes beta cell function to decline. Most patients with type 2 will require insulin at some point. Normal beta cell deterioration can be physiologic stress of illness, surgery, or hospitalization for serious injury can necessitate short or long-term insulin. Patients benefit from early explanation by providers of the progressive nature of type 2 diabetes and the need to change treatments with changing conditions. First, knowing how a particular patient thinks about insulin facilitates our giving the kind of information that helps patient take it reliably to home. Seldom is it a significant reason that people are terrified of sticking themselves with a needle, especially after receiving one insulin injection. I mean, that may be the stated reason in our mind, but doesn't really hold true because of the impact of other reasons. It's more likely it's misunderstanding about insulin. So brief and natural use of the ALE model to provide specific information that helps this patient be reliable with insulin. Our ask, listen, encourage. There are barriers, and this has been called psychological insulin resistance in both patients and professionals. So it's seen in the patient, the cultural barriers, seen by patients, unfortunately, as a sign that they are alarmingly ill, a personal failure because they've been bad and they have guilt and remorse. And which those are not motivators for self-care. That's been well studied. The shame and blame doesn't work. Self-shame and blame and others. It's not seen as a necessary step for next treatment to feel well and have a life where you can do what you need to do and want to do. Professional barriers are the reflection of the patient and cultural barriers, and can be inadequate buy-in for early explanation for probable need for insulin at some point, and belief that there's inadequate staff and time for patient education. We want to help the patient identify personal reasons for achieving glycemic control, specific motivators for that person. Not will avoid complications way down the line. Rather, walk my daughter down the aisle at her wedding in 6 months. When people want more energy for activities they enjoy, they are more open to taking insulin if they understand how it helps achieve their goals. If they want more energy for activities they need to do to support themselves and their family. So we want to do what we can to set them up for success. First, what do patients share about a resistance to taking insulin? And what patients may not openly share that certainly decreases reliability with insulin. So some of the concerns and then possible responses that you would get through a brief and natural use of ask, listen, and encourage is that people will say, well, insulin injections hurt. Well, they think they feel like flu shots or something, but it doesn't sting. Maybe Lantus a little, but nothing like the other shots, the IM shots. The needles are fine, laser sharpened, and silicone coated for ease of entry into the fat. So this where there's no nerve endings. It's not into a vein or muscle. I don't know how many people actually think that. Most people feel little or no discomfort. And the very short length of needles that are recommended today also helps. I don't think I can learn. Just about anyone, any age, can be successfully taught. I have needle phobia. Well, actually, true needle phobia is almost non-existent, and we will patiently help you. But I'm scared. It's normal to be scared when you start something new, especially something there's so much misinformation about. Now, obviously, you wouldn't roll these off your tongue really fast. They're sort of background for you to know how people think. Other concerns people have. I need insulin because I've failed. Well, provider can mention insulin in a positive light at the time of diagnosis and listen respectfully later when the patient needs to start and they may be upset. You want continued clarification of the progressive nature of the condition of diabetes type 2 and underscore that oral agents have failed the patient, not that the patient is a failure. Believing one is a failure is not motivating. It's not an impetus to improve any part of adherence. It may seem like it is, but research has shown it's not. Is insulin even effective? I have heard that it isn't. Now, goodness, where's that come from? It stems from a misunderstanding from people they know who did not take it as prescribed, resulting in high glucose and hypoglycemia at other times. And although people think diabetes is a sugar problem, point out that it is an insulin problem, and exogenous insulin, outside insulin, is sometimes needed when their own internal insulin is not sufficient. Explain that today's insulins are similar to insulin that the human body naturally makes. You can also say something like, with insulin therapy, you are taking a natural hormone, not some unusual medicine. Other concerns. Once I start taking insulin, I'll be on it forever. That old, wrong adage. Once on insulin, always on insulin. That is just, has some place in history and no longer true. Some can reduce or eliminate the need for insulin through maximizing lifestyle habits, but no promises. When a person is started on insulin for hyperglycemia from a physiologic stress, the insulin dose is usually decreased or even eliminated when the effects from the illness or trauma lets up. It's not good to try to predict how this timeline will look. And this is why the patient being given early explanation of probable need for insulin at some point is helpful without drama and with support. So more concerns, I will fall out. I'll have really low blood sugars. Well, you want to assure people that severe hypoglycemia is rare in type 2. There are warning signs and time to act. Person started on a low dose, and explain it as a complete treatment, as a balance, the many parts together. Teach the patient to take it as scheduled, recognize symptoms of low blood sugar, carry or have available correct, good treatment. We will get back to that in another program. Person says, I won't know how much insulin to give. I'm afraid I'll give myself too much, or my mother or somebody. Many think that no one takes insulin until the glucose is very high. No scheduled insulin. That's not what they've heard and I've thought. Only the old sliding scale insulin. And anxiety, that sliding scale is very complicated to calculate. And if a patient had been in the hospital, I'll tell you, sliding scale insulin there sounds very complicated because it shifts and they're explained and people don't think well, they're sick, they're tired, they're sleep deprived, and many things just don't get heard each time, maybe 4 times a day or 3 times a day they're told about these numbers. Help understand that sliding scale is seldom used. Scheduled dosing is best. Assure patients that they will be taught to drop or dial correct dose. So again, this patient has an elevated A1C, the provider increased the insulin, and then the A1C goes higher. So remember, many people think you should not take insulin until the glucose is very high. If you suspect this is going on, which is really fairly common, you could say if your blood sugar was 140 and it was time to take your prescribed scheduled insulin, what would you do? The answer will tell you if the patient thinks this counterproductive way. So again, we have our ale. Here we have the patient again, elevated A1C, increased the insulin, and A1C goes higher. Oh my goodness. Remember, many people think you shouldn't take it unless your blood sugar is high. So let's look at this scenario. The patient had not previously been taken scheduled insulin except when the glucose was very high. And they wouldn't even think they missed a dose because that was their baseline understanding. So increasing that increased dose, because the A1C was high, causes hypoglycemia when the patient actually takes it. Because remember, the new dose was based on thinking he was taking it before instead of not taking it. So the patient, because of this even more often hypo, he more often omits insulin, attempting to self-protect from hypoglycemia. Again, we have our ask, listen, encourage. And some variation on this. Your sugar was normal this time because you took insulin before. Don't stop doing what's working because it would go high again if you didn't take it. Something like that. Patient says, insulin will make my already busy life way too complicated. A really bad change in lifestyle, they may believe. So you want to identify concerns about losing flexibility and spontaneity and provide information about how insulin can make life better. You want to let them know that insulin bottles and pens in current use are not refrigerated. You don't let them get up to 100 degrees, but they're not refrigerated. No cooler required. It's amazing how many people remember their grandmother carrying a cooler to church or something. So that's something people are really interested in knowing. The insulin regimen is personalized, particularly important because people are worried about injecting in public places. So you can work with the individual, come up with a plan that works for them. Again, I'm worried I'll gain weight. Now this is a common misunderstanding, or they've seen it happen with other people. So we need to let them know that high glucose makes you hungry. So you eat more. With better glucose, control is better. The food is staying around to nourish you instead of being eliminated through the urine, along with your energy being eliminated. Meeting with a dietitian will help. In general, though this is a complicated topic, eating more calories than you burn is what makes you gain weight. And with good self-care, you can lose weight when taking insulin. It's not impossible. This patient cries when she hears she needs to start insulin. I'll tell you, this is also common. It's a belief that insulin causes complications. Now, goodness, where does that come from? It comes from people who started insulin late in their disease when complications had already begun. So they had problems, they were started on insulin, they believed the insulin caused the problems. They associate the two. By improving control with insulin, risks are reduced, complications are delayed, or sometimes eliminated. Explain that the opposite is true. Poor control causes problems, high blood sugar over time. So again, and you will have energy and you'll feel better. So we want to help people to be successful. Thank you.